So I thank the organizers for having asked me to give a pro presentation regarding distal renal tubular acidosis, and the urologists should know that and refer the patients. I want to first talk about a consensus conference that occurred 7 years ago in Rome, where a distinguished group of stone scientists from all over the world came together discussing 27 questions which had been asked in advance. They were discussed in the plenum as well as in small groups, and at the end, a consensus statement on the medical treatment and prevention of calcium stones was published in Journal of Nephrology. And one of the questions that came up there was the following: should stone patients with an incomplete distal renal tubular acidosis be considered separately from idiopathic calcium stone formers? And should incomplete distal renal RTA be searched for in all recurrent calcium stone formers? Now, first, let's make a clear statement. Distal RTA, whether incomplete or complete, is a systemic disease because we are dealing with a basic defect in the intercalated cell of the collecting tubules, where at the luminal membrane, the hydrogen ATPase is dysfunctional, and we get a chronic retention of hydrogen ions throughout the body. The major causes of type 1 distal renal tubular acidosis, you get a summary here. There is primary forms. Secondary forms occur in connection with autoimmune disorders, drugs, hypercalciuric conditions, for instance, hyperparathyroidism, and medullary sponge kidney, and so on, as you all know. There are two forms. The complete type 1 RTAs is a rather rare disease and is characterized by permanent acidemia, which means systemic metabolic acidosis, and an elevation of urinary pH. It causes hypercalciuria due to reduced tubular calcium reabsorption and pronounced bone dissolution, and hypocitraturia due to a reduced intracellular pH in the proximal tubular cells, which increases citrate reabsorption. The much more common form, as you know, is the incomplete type 1 RTAs. It's exactly the same clinically, but the patients are never acidemic, otherwise exactly the same. Important, due to the chronic hydrogen ion retention, both forms predispose to calcium stone formation, nephrocalcinosis, and low bone mass. It is important to look for this disorder because it's a prevalent disorder. Already in older times, the prevalence went up to 16.6% in a series in Denmark. Remarkable there, 25% were women, only 12% were men. More recent papers, Aram Patsis and myself in Bern, have put together 150 male stone formers. The prevalence was 6.7%. In London, there was a study done, 13.7%, both genders. A more recent study from Bern, other patients than the first one, 7.7%, but mainly men. And our study, just published in the beginning of this year online in the Journal of Nephrology, 16.6%, again 25% women, 13.6% men. In addition, it's as prevalent in patients with low bone mass as the study by Weder et al. 22 years ago, as well as the one that we published 5 years ago about similar prevalences of this disease. Again, in our series, clearly a higher preponderance of female patients versus male patients. Now, what I'm going to talk to you now is all about our study that we have published, because it's probably the largest cohort that ever has been screened for this disease. It's based on a consecutive stone forming group of 531 non-selected kidney stone formers seen over 11 years. 80 of them had uric acid, infection, or cystine stones, so they fell apart. 65 were calcium stone formers due to secondary form of disease, bariatric surgery, primary hyperparathyroidism, inflammatory bowel disease, medullary sponge kidney carboanhydrate inhibitors. So we were left with what we believed were 386 idiopathic calcium stone formers. We screened them all for incomplete distal renal tubular acidosis. The screening was done by fasting urine pH after 12 hours of fasting. Whoever had a pH above 5.8 underwent ammonium chloride loading. After the test, I will show you that later, we found that 321 patients had normal urine acidification, 1/4 women, 3/4 men, mean age 51 years. 65 had a distal RTA, 1 was complete, 64 were incomplete, 41% were women, so clearly more than in the idiopathic calcium stone formers, 59% men, and the mean age was 44. So these patients are more female and clearly younger than the idiopathic calcium stone formers. So in order to make a more equilibrated comparison, we did a matched pair comparison. We found 62 idiopathic calcium stone formers, which we could match to 62 patients with incomplete distal RTA and calcium stone disease. They were matched for age, gender, BMI, and serum creatinine. And when we now compare these two groups, we have come up with another important statement. Incomplete distal RTA goes along with a clearly greater morbidity. The stone disease is more active, number of stones per years of disease 1.5 times higher. We find a higher prevalence of patients with intrarenal calcifications in those with iRTA. If you then went on to CT scans to calculate the number of calcifications that were encountered in both kidneys, 2.5 times more calcifications in iRTA, and a significantly higher percentage of patients with low bone mass in comparison with the idiopathic calcium stone formers. Because the study lasted long and I had the possibility to talk to patients after 15 years, we observed in single cases a transition from incomplete into complete distal RTA and a strong increase in number of intrarenal calcifications in one woman from 15 to 49. So it's active disease if not treated. Now, before you treat it, you should know how to diagnose. The diagnosis is basically easy. The screening is done by measuring urine pH. However, many colleagues say you can just take the 24-hour urine pH, and if it's above 5.5, there is a strong suspicion. Do never use 24-hour urine pH to diagnose this disorder because it's totally diet dependent. What we usually do, we take the second morning urine after 12 hours of fasting. If the pH is above 5.8, incomplete distal RTA is possible. To confirm the diagnosis, you need a challenge with ammonium chloride loading. The classic test by Wrong and Davis was obtained from 10 normal subjects who got 100 milligrams of ammonium chloride per kilogram body weight. And if the urine pH fell below 5.3, that was a normal pattern. The average of the pH fall was about 0.7 pH units. This requires serial blood and urine measurements in a hospital unit, and a problem is that is frequently present is gastrointestinal irritation and strong vomiting. We have developed over the years an outpatient test which can be done at home. We use half the dose of Wrong and Davis, which we consider a more physiologic acid load. We did that in 21 normal subjects. They got this dose divided in 3 parts, 25 minutes before main meals on day 1. After an overnight fast of 12 hours on day 2, we measured in second morning urine the pH, and if the pH dropped below 5.45, 0.6 to 0.9 pH units in our subject, this was the normal pattern. This test never caused vomiting and only slight nausea. So we basically get the same because the major criteria of Wrong and Davis test is the drop in pH. Now, iRTA can successfully be treated. However, it's a long-term alkali treatment, so adherence is always a problem. what many patients and sometimes physicians do not understand. We do not give alkali for altering the urinary pH because it's high anyway. We want to tremendously increase the buffer capacity in order to neutralize the retained hydrogen ions and therefore avoid nephrocalcinosis, bone disease, and so on. In our study, we prescribed or suggested 40 to 60 milliequivalent potassium citrate per day, and we were able to follow patients up to 15 years. And after this time, I did phone calls. I found 30 who had completely adhered to this regimen, and they had in 33% clinical stone event over these years. The non-adherents had 53% stone events. This was significantly higher. And if we looked at the activity of the stone disease in these rather young patients, the non-adherents had a 5.5 times higher stone activity during the observation period. This was highly significantly, statistically significant different. So I can summarize with the consensus statement of that paper. I totally agree with that. Given the relatively high prevalence, the possibly associated conditions, as well as the therapeutic consequences, incomplete distal RTA should be distinguished from idiopathic calcium nephrolithiasis. It's a different disease. Incomplete distal RTA should be searched for in stone formers with hypercitraturia and, of course, most important, less acidic urinary pH, fasting pH above 5.8, or unexplained recurrent hydroxyapatite nephrolithiasis or even nephrocalcinosis. And here comes my conclusion. Urologists should know incomplete distal RTA and refer patients to nephrologists for evaluation and treatment. Thank you for your attention.
To be honest, when I first got from Professor Buchholz this assignment to be to one of the leading experts in metabolic evaluation of the urolithiasis, Professor Hess, I was scared. I was petrified. I have a problem. But after that, it becomes easy and good for me because I understand that I will have the great basis for this talk, and I will just need to talk the way how we get here and maybe some points why we are not here. First of all, I would like to make my disclosure statements. I love stone. I'm a urologist, both at home, both at work. All of us love stones. We want to see stones, we want to break stones, so this could be a significant potential of bias for all of us. Our heritage as urologists is coming from giants like William Jesselyn, like Frere Jacques, who says, I have removed the stone, now I will leave it to God to heal the patient. The first urology unit is called Founding and Teaching Practice of Stone Removal. This is where all started. I believe that to see how we will go further, we need to see how we come where we started. For centuries, there are no nephrologists. This is a significantly new and extremely valuable specialty, but it is about 70 or 100 years old. For centuries, surgeons dedicated to urologists were the physicians responsible for their treatment in all their vicinity. In the last quarter of 20th century, two very significant from our point of view things happened. The first was one very small letter to the editor who says that there is some signs of genetic predisposition for kidney stones. And the second one is the ability to diagnose those kidney stones with implementation of X-ray. The 20th century brought many other breakthrough findings like the Randoplex. Secondly, maybe the most important of all, there is a sign of association between morphological lesions, metabolic abnormalities, and calculi formation itself. Furthermore, every stone type Hess, it's a different type of underlying metabolic abnormality. And where are we now? We are talking about omics, we are talking about genes. This is a simple scheme of the genes included in distal renal tubular acidosis. But why we are not there yet? The first graph shows the utilizing of urine evaluation, metabolic urine evaluation, as a very rough surrogate for nephrology referral. The percentage is 1 digit. Maybe at the patients which have been through stone surgery, maybe this could be a little pride for the urologists. I want to believe that this high percentage is due to urology referral for further metabolic evaluation. Even more, we are seeing that we don't have very significant tests because the frequency of recurrent stone former is almost the same in normal and in abnormal urinary analysis. Is it possible that providers do not interpret and perform the investigation correctly? Maybe the patients did not adhere to all the prescribed treatment. Maybe the biggest problem is the serious overlap between healthy individuals, first-time stone formers, and recurrent stone formers. Although in the last years urine chemistry were analyzed, they were unable to really distinguish a group of patients that will have any benefit from metabolic treatment. Multiple pharmacological interventions trials have demonstrated that non-interventional groups have the same stone recurrence. In a subset of stone formers, simple measures like high fluid intake, reducing salt intake, moderating animal protein may be enough to prevent the recurrent stone event, and this could easily be prescribed by any healthcare practitioner. The biggest problem until now is that we have a discrepancy between serious breakthrough in the basic science and these implementations of this breakthrough in the bedside science. We have a lot of extremely important information, but this, until several years ago, doesn't lead to new treatment. Compared to empirical therapy, let's say calcium citrate prescribed to every stone former, specific preventive pharmacological therapy guided by urine analysis hasn't been able to lead to a recurrence rate drop. What are the pitfalls in the clinical interpretation, in the bedside interpretation of distal renal tubular acidosis? Distal renal tubular acidosis has a confirmed comprehensive pathophysiology. We know its genes, we know exactly what happens, but its incidence is very narrow. It's about 1 of 600. So the urologists rarely see such patients. They have been diagnosed in adulthood, in adolescency, and the secondary distal renal tubular acidosis is rare also, and it's known because we know from the primary disease. What are the clinical pitfalls of this new and very interesting concept of incomplete distal renal tubular acidosis? Approximately 12% of the so-called recurrent idiopathic stone calcium formers have incomplete distal renal tubular acidosis. Prevalence was significantly higher in women, at least 1/4, than in men. But urinary acidification capacity is probably not a dichotomous. We don't have a clear border between health and disease, but it is a continued trait in stone formers. According to this hypothesis, stone formers with incomplete distal renal tubular acidosis correspond to the lower range of the acidification capacity. If we ask what distinguishes as in terms of treatment, of recommendations, patients with iRTA for most calcium stone former, there is much overlap and no clear separation are seen. Hypocytraturia, hypercalciuria, reduced bone mass density have all been suggested as to be characteristic of incomplete distal renal tubular acidosis, but of course, these are characteristic of many much more calcium stone formers. Important clinical issue in iRTA is whether this condition should be specifically investigated, since functional tests for each diagnosis are complex, they are performed in academic centers, they are time-consuming, and treatment of renal stone formers with iRTA is similar to that of patients with idiopathic calcium nephrolithiasis. Semantics aside, but incomplete distal renal tubular acidosis is 1.5-fold more prevalent among female idiopathic calcium stone formers. It is proven that incomplete distal renal tubular acidosis predict more stone recurrences, predisposes to calcium phosphate stones formation, and it is connected with 2.5 times more intrarenal calcifications when compared to calcium stone formers without incomplete distal renal tubular acidosis. And as we know, chronic alkali treatment reduced clinical stone recurrence by a factor of 0.55. As a conclusion, I should say my conflict of interest. I do believe that the urologist should know, I think to a degree, and should refer definitely. So I'm defending the thesis on this, but deep inside me, I think that this should be done. The creation of lithiasis units, stone clinics, urolithiasis MDT, whatever we call them, which should be an ideal platform for this. We as a team have a lot to do because urolithiasis is a nephrological disease as a basis with the urological complications. Thank you so much for your attention. And